So thanks for the invitation to speak, and thank all of you in the room and online for sticking around until the end of the day. And I hope that I can take the day out with a bang and really make this interesting for you. So we've had a fantastic day of speakers across a range of topics. We've done a really deep dive, I think, into respiratory infections. We've also talked about how we can improve access and delivery of vaccines, but with a very Australian lens. And I think that's very important because we're here in Australia. But really what I want to do is take a bit of a zoom out to the wider global landscape and touch on some diseases that you may be familiar with, some you may be less familiar with, but that your patients may ask you about. And it's great to see that there's so many vaccine providers and clinicians here in the room, because I think hopefully I've chosen some diseases that are of interest, both because they're topically globally, but because we also have vaccines to prevent them. So over 200 years ago, Dr. Edward Jenner really made the first successful vaccine against smallpox, and that really set in motion a chain of events that led to the eventual eradication of smallpox, which to this day is still the only human disease we've ever successfully eradicated. And fast forward to today, and we've got vaccines for over 24 diseases. Yet paradoxically, and as we've heard throughout the day, vaccine preventable diseases are resurging in many parts of the world. And why is that? Well, I mean, the answers globally are the same as many of the answers we've heard today in the room. Access to vaccines remains unequal. Access is an ongoing big problem. Vaccine hesitancy is on the rise. And also the COVID pandemic really disrupted immunisation programs globally. But I think there's also a flip side, and maybe a more positive thing, is that we're entering a new era of vaccine innovation. We've got new platforms that are enabling faster, more adaptive vaccines. And these advances are really reshaping how we prevent diseases and making vaccines more available, not just in children, but across the lifespan. But why does the global situation matter to us here in Australia? Well, I think it's because we live in an interconnected world, and a vaccine preventable disease anywhere is a threat everywhere. So in the next 18 minutes, I'm going to take you on a rapid fire tour of not one, not two, but 9 diseases. So I'm going for breadth over depth here. And really talk about what's happening globally, what's in the vaccine pipeline, and what you as providers need to know about. And to make sense of this global landscape and keep this whirlwind tour a bit manageable, I'll be presenting them in groups of 3 according to their modes of transmission. So I'll start with person-to-person transmitted diseases. I'll then move on to more fecal-oral environmental diseases. And finally, I'll finish with some vector-borne diseases. And I think even if you don't do travel medicine or don't give travel vaccines, you will see patients who travel. So I think there'll be something relevant in here for everyone. So I wanted to start with influenza, and it's the first person-to-person transmitted disease and the only respiratory disease I'm going to talk about. During the early pandemic, influenza activity dropped sharply due to border closures and public health measures. I think we all know that. But by 2023, and this is global data, you can see it had made a strong global comeback. And the activity has returned to, and in some regions exceeded, pre-pandemic levels. Influenza remains the most common vaccine preventable disease in travellers, with an estimated incidence of around 1 to 3 per 100 travellers per month. So it's very high. The risk is especially high in certain environments like cruise ships and at mass gatherings where there's a lot of people mixing in close quarters. In Australia, influenza vaccine is recommended for everyone aged 6 months and older. And because protection wanes over time, those who are vaccinated early in the season can potentially be given another dose of the vaccine later in the season, particularly if they're travelling to the Northern Hemisphere in the kind of October to May part of the season. So you can offer people a second dose. If they've had a NIP dose earlier, then they'll have to pay out of pocket for it. As for what's new in influenza, I think since 2013, we've been using quadrivalent vaccines to cover 2 flu A and 2 flu B lineages. But from 2025, we're transitioning back to trivalent vaccines. And that's really because B Yamagata, one of the flu lineages, has not been detected globally since 2020. It seems to have been a victim of the COVID pandemic. There are adjuvanted and high-dose vaccines that will remain available for older adults. There are some new recombinant vaccines in the pipeline on the horizon. And there's also talk about combination vaccines, like a combination flu COVID vaccine, which may become available to us and simplify protection for people in the future. Next, to measles, and I know Andrew's already covered this and he's done a great job of talking about all of the clinical features and so on. I just wanted to touch briefly on the global epidemiology. And so like with influenza, we saw measles activity drop sharply during the COVID pandemic, but since 2023, we've seen a strong global resurgence. And people often dismiss measles as a benign childhood illness, but as we've heard, it can cause pneumonia, encephalitis and death. And there are an estimated 100,000 deaths globally in 2023. I think also it's important to note that measles is an ideal sentinel disease because it's got a typical syndrome, it's usually symptomatic, we have a diagnostic test for it. And it's a bit like a canary in the coal mine. It's sort of a sense that we're not getting good immunisation coverage. And often we see outbreaks of other vaccine preventable diseases follow measles outbreaks. So I think we should think of this global outbreak situation as a warning and a call to action that we need to improve immunisation coverage. And I'm really glad to see that our national immunisation strategy is focused on doing exactly that. So in terms of measles vaccination, as we've heard, the key risk factor for infection remains being under or unvaccinated. NCIS has this nice graphic which talks through what you should do based on someone's immunisation status and their year of birth. The Cliff Notes version is that if you were born between 1966 and the mid-1990s, you're more likely to be at risk. And if you don't have documentation of having received 2 measles-containing doses, then you're unlikely to have natural immunity. Therefore, you should be offered vaccination unless you have a contraindication to that. And so what's new and what's next? Well, there's a potential shift to earlier age that's being discussed at the moment. At the moment, you can give measles vaccination down to the age of 6 months, and we often do this in travelling infants to give them protection, but that dose does not count towards the schedule, so you still have to give doses at 12 and 18 months. Some countries do give their routine first dose of measles at 9 months, so there's variability globally, but here in Australia, if you give a dose before 12 months, you still have to give 2 additional doses. There are some potential new combination vaccines being developed, such as MMR yellow fever vaccine in countries that have both of those vaccines in their national schedule. And there's also been some trials around microneedle patch vaccines, such as measles rubella vaccines in parts of Africa, where access and particularly rolling out vaccines without a vaccine fridge is a really big challenge. So, moving on to the next disease, Mpox, formerly monkeypox, which is caused by the Mpox virus. And this virus has 2 clades. So, globally, we had a large clade 2 outbreak that started in about 2022, which has primarily affected gay and bisexual men who have sex with men, but not exclusively. And there's been over 100,000 cases of that clade reported globally worldwide. Perhaps more concerningly, since January 2024, we've seen a separate clade 1 outbreak, and this is a clade that emerged in Central and East Africa, but is more severe and is more likely to cause death, whereas clade 2 tends to be a milder disease. And we had our first case of clade 1 Mpox detected in Australia just last month, which was an imported case from Central Africa. Transmissions via close physical contact, including sexual contact, and the virus is present in respiratory droplets, skin lesions and bodily fluids. So it tends to be sexual contacts and household contacts that we see this disease in. So in terms of Mpox vaccination, this remains a key preventive tool, and it can be used both as pre-exposure and post-exposure vaccination. We have a 3rd generation non-replicating modified vaccinia Ankara vaccine called Jynneos, which is known in other parts of the world as Invamex or Invamune. It's used in many countries, including Australia, for both pre- and post-exposure prophylaxis. It's given as 2 doses subcutaneously or intradermally, 28 days apart, and it has a favourable safety profile, and it's inactivated, so it can be given to people who are immunocompromised. ATAGI is now recommending pre-travel vaccination for anyone who may engage in sexual risk activities while travelling to countries with clade 1 Mpox transmission. But there's a little bit of variability in eligibility criteria by state and territory, so I'd encourage you to look at your jurisdictional guidelines. So in terms of hepatitis A, epidemiology. So this is, again, among some of the most common vaccine-preventable diseases acquired in travel, and it's the first fecal-oral transmitted disease I'll discuss. The risk is highest in Africa and South Asia, and a recent geosentinel analysis identified Morocco, India and Pakistan as the top countries of exposure amongst travellers. While most of the cases occur in low and middle income countries, we do sometimes see outbreaks in high income settings. It's often linked to contaminated food and often imported food, or among groups that have increased exposure risk, which include gay and bisexual men who have sex with men. In terms of hepatitis A vaccines, this vaccine is recommended for all adults and children aged 1 year and older who travel to endemic areas. We have a number of monovalent vaccines available both for adults and kids, where a single dose provides protection for the upcoming trip and for several years. A second dose is recommended 6 to 12 months later, and that's really to increase the duration of protection. And we generally think in an otherwise healthy person that 2 doses of hepatitis A vaccine protects for decades. If hepatitis B protection is required as well, you can use combination A and B vaccine, and there is a rapid schedule for that if people need to be quickly vaccinated before they travel. An important practice point, though, is that although there are different manufacturers that use different units, the monovalent hepatitis A vaccines are considered interchangeable, but they're not interchangeable with the combination A and B vaccines. And that's because the combination A-B vaccine contains half the hepatitis A antigen dose. So it's just an important thing if you're thinking about interchangeability of vaccines. Unfortunately, the combination Hep A typhoid vaccine that we used to have has now been discontinued. So that is no longer available, which means if people need protection against both diseases, they need 2 vaccines. So speaking of typhoid, this is the global data on typhoid incidence rates, which shows, again, the highest burden of disease is in South Asia and also in parts of the Eastern Mediterranean and African regions. Traveller groups who are at risk include visiting friends and relatives travellers, young children and long-stay travellers, such as expatriates and aid workers. And amongst Australian travellers, the highest incidence has been seen in those visiting South Asia and some Pacific Island nations like Samoa. In terms of vaccination, it's recommended for those aged 2 years or older who travel to endemic areas, and we have 2 vaccines available in Australia. There's Typhon VI, which is an inactivated polysaccharide vaccine that's given as a single intramuscular injection, and Vivotif Oral, which is a live attenuated vaccine, which is taken as enteric-coated capsules that need to be swallowed whole, as the stomach acid can inactivate the live bacteria. The standard schedule is 1 capsule every other day for 3 doses. A 4-dose schedule provides longer protection, so out to 5 years. In some typhoid endemic countries, there are newer vaccines, which are called typhoid conjugate vaccines. We don't yet have them available in Australia, but they do offer improved efficacy and longer lasting protection, and they can be administered from as early as 6 months of age. So it's valuable for childhood programs in these endemic countries, and hopefully at some point in the future we'll see these in Australia too. Next to polio, the last of our fecal oral or environmental diseases. Since the launch of the Global Polio Eradication Initiative, or GPEI, in 1988, we've seen global cases of wild poliovirus drop by over 99%, and polio remains endemic in just 2 countries, Pakistan and Afghanistan. But unfortunately, the job isn't done, and in areas where there's low immunity, the oral polio vaccine, or OPV, while it's highly effective, can mutate and cause circulating vaccine-derived poliovirus. And these outbreaks have increased in recent years, and based on data from earlier this week, there were 47 outbreak countries with these circulating vaccine-derived polioviruses. To address this, the global eradication strategy includes phasing out the oral polio vaccine with a full transition to inactivated polio vaccine, which is what we use in Australia, but we can't do that until wild polioviruses have been eradicated. So in Australia, we only have IPV, and travellers who have completed the primary schedule are recommended to have a booster every 10 years if they're visiting affected regions. We have both monovalent polio and combination diphtheria, tetanus, pertussis polio vaccines, and the latter are often a convenient way to update polio immunity as well as immunity for other diseases which are resurging globally, such as pertussis. Okay, moving on now to our vector-borne diseases, and I'll start with dengue. So dengue is widespread across the tropics. There was a recorded 14.1 million cases globally in 2024. And this only represents a fraction of the true burden due to surveillance gaps, especially in Africa, as well as asymptomatic and undetected cases. In early 2025, the highest notification rates have been seen in the Americas. And for travellers, the risk is estimated at around 0.3 to 6 per 1,000 travellers per month. It is one of the most common diseases we see in Australian travellers, or one of the most common vaccine-preventable diseases we see in Australian travellers, with over 2,000 cases in 2024, almost all of which were imported. So while most infections are asymptomatic, severe dengue infection remains a leading cause of hospitalisation and death in endemic areas. Dengue is caused by a flavivirus that has 4 serotypes, and after a primary infection you develop lifelong protection to that serotype, as well as short-term cross-protection to the other serotypes. Severe disease is 2 to 3 times more likely with a secondary infection compared to primary infection, but that's only if you get your secondary infection more than 12 months after the primary infection, because that's about how long this cross-protection lasts. The explanation for that is complex, but one of the phenomena that contributes to that is something called antibody-dependent enhancement, or ADE. So dengue vaccines aim to prevent severe disease, but in people who have never been exposed to dengue before, there's a potential paradoxical risk of worse outcomes. And that was seen with the first dengue vaccine that came onto the market, Dengvaxia. And unfortunately, that's really led to a decision to discontinue the vaccine because there's not demand for it globally. So where are we at with dengue vaccines now? Well, the only vaccine for which we have a TAGI advice is Dengvaxia, which is now no longer being manufactured. For Cadenga, which is the vaccine that's available throughout most of Europe and has been approved by the European Medicines Association, it's only available in Australia via the SAS. It's a 2-dose schedule given at 0 and 3 months. And there's also a third vaccine which is in phase 3 trials that's being developed in Brazil, but probably not going to be available in other countries at any time soon. So we don't have a target advice for Cadenga yet. We probably will have at some point in the next 12 to 18 months, depending on how things go through the TGA. But at the moment, it's only being selectively used because of its SASB categorisation, mainly for people who have had a past history of dengue who are going to have long stay travel or frequent travel to dengue endemic areas. I just wanted to touch on what we can maybe learn from the use of this vaccine overseas. As I said, it's available in Europe and there's been widespread use in some countries, including Germany. There's a lot of variability in the recommendations between different countries, with some countries limiting its use to people who have had past dengue and others being more liberal. In terms of post-marketing surveillance, reactions are more common with the first dose of vaccination. They're the kind of reactions we'd expect to see with any live vaccine. And they're most pronounced 7 to 11 days post-vaccination, which for those of you in the room who give a lot of vaccines is probably not surprising given this is a live vaccine. So headache, myalgia, malaise and fever are probably some of the more common ones. There's some data suggesting that breakthrough cases can occur in those who have been vaccinated. They've mainly been seen in those who have only had 1 dose of the vaccine. And in people who have a history of vaccination, there's a lower hospitalisation rate, suggesting that the disease is milder. Another interesting sort of safety signal is there's been an increased frequency of anaphylaxis reported with a median time of 25 minutes. So just if you're giving this vaccine, it's important to be aware that people need to stay afterwards for monitoring, as we would do usually. Next, chikungunya. So last year there was a record 620,000 cases reported globally. And that was concentrated in the Americas. And in 2025, we've already seen 200,000 cases, including in the Americas, but it's now spread to other places, including across the Indian Ocean, to countries like Sri Lanka, and also it's been seen in some of the French territories, Réunion and Mayotte. It's an arthritogenic alpha virus. So you'd be aware of Ross River virus. It's the same family of viruses that causes Ross River. So it can cause joint pain, swelling in multiple joints with long-term sequelae, potentially lasting months to years, especially those who are older and those with comorbidities. Unlike dengue, it has a single serotype, and as far as we know, infection's thought to confer lifelong protection. So it causes these explosive outbreaks where it kind of blows through a community, causes lots of cases, and then disappears again. But interestingly, Réunion has just had a large outbreak. About 30% of their population has had chikungunya, and their last outbreak was 2005, so it's been about a 20-year lag, and that's probably reflective of maybe when you've got a large enough cohort to be reinfected with this virus. So where are we at with chikungunya vaccines? Well, there are 2 vaccines now available in the US and Europe, and both of them are single-dose vaccines. IXCHIQ is a live attenuated vaccine, which is licensed in the US from the age of 18. And then VIMKUNYA is a virus-like particle vaccine that's licensed in the US from age 12. And if you're not familiar with virus-like particle vaccines, these are recombinant, self-assembling viral proteins that have no genetic material, so they're not live. It's the same technology that's used in Gardasil and Engerix-B. US ACIP recommendations, so that's the equivalent to a TAGI in the US, are recommending chikungunya vaccination for those travelling to areas with chikungunya outbreaks. It's important to note another safety signal. The US ACIP and also the European Medicines Association have currently recommended a pause on using chikungunya vaccine, specifically IXCHIQ vaccine, in people aged over 60, because there have been 17 serious adverse events, including 2 deaths. So this is still under investigation, but it's a safety signal that it's important to be aware of. Neither of these vaccines are currently available in Australia, but they may be available soon, or people might be seeking them overseas. The last disease I was going to touch on very briefly is tick-borne encephalitis. So tick-borne encephalitis is focally endemic from Western and Northern Europe through to Northern and Eastern Asia. And there's around about 10,000 cases reported a year. As the name suggests, it's spread by ticks, specifically Ixodes ticks. Most infections are asymptomatic. It can cause acute meningoencephalitis with or without myelitis. Probably clinically the most related disease that you'd be familiar with is Japanese encephalitis. They're the same family. They're both flaviviruses, and they cause similar syndromes. Europe, I guess, is the interesting story here, because with warming climates, they've seen expansion in tick-borne encephalitis areas, and you can see the endemic areas in Europe are particularly the Baltics, Scandinavia, and Central Europe. It's a highly seasonal disease, so it peaks typically in around about July, but almost all transmission occurs between May and November. The risk in travellers is low, but it's higher in people going to these highly focal areas, and the risk areas are expanding. So what's available? There is a tick-borne encephalitis vaccine that's available through the SAS. It's not registered in Australia, but it can be imported. Who would you give it to? Well, it's really travellers who are going to be hiking or camping in forested endemic areas during the peak season. So particularly those longer stay travellers, you might think about it in. The primary schedule is 3 doses, usually given over a 12-month period. So it's quite difficult to get into travellers before they travel. It's one where often you might try to get a rapid schedule into people with 2 doses at 0 and 14 days showing greater than 90% seroconversion, and then potentially getting people to follow up with a clinic in Europe where the vaccine's much more widely available and much cheaper. So that was a whirlwind tour. But hopefully I've convinced you that vaccine preventable diseases cause a substantial health burden in travellers and that they're increasing globally. The risk for your travellers is going to depend on where they're going and what they're doing. But I think it's really important, as we've heard throughout the day, that travellers are up to date with routine vaccines, and I think a particular focus on measles at the moment, given the global situation, as well as the recommended travel vaccines, especially for those at higher risk. Thank you.